in order to preserve the leaflet motion. So this is the diagram showing the yellowish color, the leaflet. Anteriorly, we can see the anterior mitral leaflet, which is having a base continuing with the iotomitral curtain. On the right side of the iotomitral curtain, we can see a right trigone, and left to it is a left trigone. The shape of the annulus varies throughout the cardiac cycle. During the diastole, it is grossly circular, as shown in the diagram, wherein systole, it appears as a kidney shape, wherein the anteroposterior diameter significantly smaller than the transverse diameter. This diagram shows the.
Your slide looks cropped. It's not moving the right way. Half of the diagram is cut off.
This one, sir?
No. Your diagram on the right side is completely cut off. Now it's better. No. Yeah, now it's better.
This is okay, sir.
Yeah. Go to the next one.
Yes, sir.
Yeah.
Yes, sir. In this diagram, we can see the angle between the aortic annulus and the mitral annulus, which has to be 120. If it is less than 120, we can get a systolic anterior motion and get a LVOT obstruction. And the lower diagram shows the three-dimensional image wherein it's a shape of a saddle shape. This slide shows the relationship of the annulus with the vessel, that is circumflex artery, and the coronary sinus. On the lateral aspect near the anterior commissure, we have a coronary sinus which is lateral most, and then then comes medially the circumflex. When we reach the posterior part of the annulus, the circumflex becomes very close to the annulus than the circumflex artery. So this relationship is important. And near the anterior right trigone, we have a bundle of his which plays an important role while taking a sutures near the annulus. Coming to the leaflets, there are two leaflets.
Go back to the previous slide. The easier way to remember the important structures around the mitral annulus is to visualize it as a clock. Okay, the AV node is between 1 and 2 on the clock. The coronary sinus is between 5 and 7. And then the circumflex artery is between 9 and 11. So if you remember this as a face of a clock, you will remember these important structures instead of reading all this theoretical thing. Okay, when you are operating, when you see the mitral annulus, you must know where the important structures are. 2 o'clock, 5 to 7, and 9 to 11.
Yes, sir.
Okay.
There are two leaflets, anterior and posterior leaflet, separated by two commissures. The leaflets are opening and closing structures of the valve. Free motion of the hinge is necessary for optimal opening of the valve. The optimal closure implies a precise fitting between the surface area of the leaflets and the orifice area of the mitral valve. This image shows the anterior leaflet and the posterior leaflet and the long axis view of the mitral leaflet in close to aortic valve. The anterior leaflet, also called the aortic leaflet, has a trapezoid shape. The base, which measures 32 plus or minus 1.3 mm, is inserted on the aortomitral curtain and the adjacent fibrous trigone. The leaflet is divided into a proximal zone and a distal zone. Proximal zone, which is an atrial zone, and the distal zone is a rough zone, which takes part in the coaptation, and it is also a rough zone. So the coaptation height is around 7 to 9 mm, ensures the competency of the valve during the systole, regardless of the physiological variation of the ventricular volume and pressures. During diastole, the anterior leaflet divides the left ventricle into two functional areas, the inflow chamber and the outflow tract. So the leaflets are divided into three segments on the basis of the indentation on the posterior leaflet. Correspondingly, on the anterior leaflet, we have a nomenclature with A1, A2, and A3 scale. So the anterior commissure, where we can see a left atrial appendage. From there, A1 is nomenclature, and on towards the medial aspect, A1, A2, and A3. And similarly, on the posterior mitral leaflet, we have P1, P2, and P3. The commissure, which is also important. It is a functional entity consisting of two different structures, providing a continuity between the anterior and posterior leaflet. The commissural leaflet is a small triangular segment of the leaflet tissue, which is supported by a fan-like chordae beneath it, as shown in the diagrams. Suspensory system, which consists of a papillary muscles and a chordae. Functions are, it helps in opening of the leaflet during diastole and prevents an upward displacement of the leaflet above the plane of the annulus during systole. The papillary muscle actually is divided into five types on the basis of their morphology. It have a single head generating numerous cord. Type 2 is multiple heads attached with a numerous cord. 3 is narrow and having few chordae. Fourth is an arch-shaped papillary muscle, while fifth is an adherent to the left ventricle. So these are the 5 types of papillary muscle. Fourth one is arch-shaped, and fifth is attached to the left ventricle. The arterial supply to the papillary muscles are very important, wherein the anterior papillary muscle receives from multiple sources, that is, and left anterior descending and diagonal, and sometimes marginal, while posterior medial receives blood supply from circumflex artery and right coronary artery. This makes the difference between the papillary muscle vascularization, which is more, in which posterior medial papillary muscle is more prone for necrosis and dysfunction than the anterolateral papillary muscle. The caudate tendinae, which are of 3 types, that is basal, intermediate, and marginal. Basal extend from the papillary muscle or direct from the ventricular wall. The basal chordae are attached to the base of the posterior and commissural leaflet or to the annulus. Intermediate chordae extend from the papillary muscle. The intermediate chordae are attached to the ventricular side of the leaflet. The marginal chordae are attached to the margin of the leaflet. The space between the two marginal chordae does not exceed 3 mm from their attachment to the leaflet, is often bifurcated or trifurcated. Coming to pathophysiology, preoperative valve analysis, and surgical indications. The Carpentier explains the mitral valve pathologies into 3 as a pathophysiological triad, that is the etiology, lesion, and dysfunction. Etiology, that is the cause of the disease, which results into a result from the disease, and dysfunction, which is a result from the lesions. So we have a classification, that is etiology of valvular disease and mitral valve lesions. Primarily, it may be a congenital inflammatory disease, rheumatic, lupus, or valve sclerosis. In degenerative disease, we have Barlow's, Marfan's, and fibroelastic disease. Bacterial endocarditis, valvular or annular calcification, trauma or tumors. Secondary to myocardial disease, that is ischemic cardiomyopathy, dilated hypertrophic cardiomyopathy, myocardial sarcoidosis, and endomyocardial fibrosis, and myocardial tumors. So on the right side, the table shows the lesion involved on the basis of the structures, that is annulus, leaflet, commissures, papillary muscles, or left ventricle. So in vegetation, most of the time, if a single leaflet or if a localized vegetations are there, then it's better to repair. While in complete AML vegetation is there, along with the aortomitral curtain involvement and aortic valve involvement, it is better to replace than a repair. In rheumatic heart disease, it is actually grouped into three groups: group 1, 2, and group 3. It's based on the severity, wherein the group 1 and 2, there is a pliable leaflet, wherein group 3, there is non-pliability and severely calcified leaflets. In conditions wherein both commissures are involved, then a replacement is a better option than a repair. In degenerative mitral valve pathology, like myxomatous, when we see surgically, the structures in myxomatous, the chordae are thick, and the annulus is dilated. Most of the time, there is a leaflet involvement with multiple jets. While in fibroelastic disease, the annulus is small, with left atrium and left ventricle being smaller, and the chordae and leaflets will be thin, and these have a unileaflet pathologies than a bileaflet pathologies. Barlow's floppy valve, which is classified into simple Barlow's and severe Barlow's. Simple Barlow's, wherein along with the prolapse, there is a posterior commissural involvement, which is almost always repairable. While in severe Barlow's, along with the leaflet, it is the leaflet calcification which is more present. So it is more amenable for the replacement than repair. Before going into repairs, we have to analyze the valve transthoracically as well as transesophagally. Transthoracic echo gives us a brief idea about the morphology of the mitral valve, in which we can see basically only two segments, that is A2 and P2 of the mitral valves, in which we can see the vegetation, the mitral valve thickness, the thickness of the chordae, restricted posterior mitral leaflet, doming of AML, which is seen in RHD, and some of the echocardiographic supporting findings like dilated LA, LV morphology. In short axis, we can measure the orifice area of the mitral leaflet, and we can also see, if we put a color mode in the short axis, the jet from where it is arising. Transthoracic echo gives us a more idea about every segments of the mitral leaflet, but it adds on a hemodynamic variation, which is conducted in the operation theater. So I would like to show you one demonstration, sir. Is this model visible, sir? This is a transesophageal echocardiography application. We can visualize, sir. In the mid-esophageal, I am advancing my probe, sir. Is it visible, sir?
Yeah.
Yes, sir. I am advancing the probe to mid-esophageal level, sir. Yes, sir. Yes, sir. This is the mid-esophageal level, wherein we can see a fourth chamber view, left atrium, left ventricle, and closer to the yellow bar, we can see a left atrium. Sir, indicator is okay, sir. The marker is visible, sir.
Yeah,
Left
go
atrium,
on.
left atrium, the mitral leaflets, and the LV. On the right side, we can see the RA and RV. This is the four chamber wherein we can appreciate the A2 and P2 segment of the mitral leaflet, sir. If we withdraw the probe, we can see the five chamber view wherein we can see a A1 and A2. A1 and P2, P1 segment of the mitral leaflet were in five chamber view. On further advancing, four chamber we will get. In this, if we increase the angle, that is at 60 degrees, we will get a bicommissural view. Here we can zoom and see the mitral leaflet in close. Yeah, this is the bicommissural view, sir, wherein we can see the left atrial appendage, and which is very close to P1 segment, and the in between part is the A2 major segment from the image also, and the posterior part is P3, the near the septum. So P1, A2, and P3 segments. That is at 60 degrees. Bicommissural view. Further increasing the angle to 90 degrees, we can see a whole part of anterior leaflet and P2 segment of the posterior leaflet. Here the anterior leaflet from lateral to the coaptation area, that is A3, A2 and A1, sir. This is at 90 degrees. If we increase the angle further to 130, we can get a LVOT, that is a long axis view. If we zoom out, it's more clear. Yes, sir. This is the long axis view wherein we can see the left atrium, mitral valve leaflets, LV, and then the LVOT and the aortic valve opening. In this segment, we can see an A2 and P2 part of the mitral leaflet, and along with that, we can appreciate if SAM is there or not post-operatively, post-repair. Yes, sir. So this was the assessment, and this is the summary of the all what I have said: 60 degree, 90, and 130. Total segments we can appreciate in each. So we have classified all these lesions into basically four types, in which Carpentier has explained a type 1 having a MR with a normal leaflet motion, which includes annular dilatation, perforation, and tear or vegetation. Type 2 will says excessive leaflet motion, which involves a MR which is associated with caudal rupture or elongation, or papillary muscle rupture or elongation, while type 3A will suggest which is almost always associated with rheumatic valve disease. The valve motion is limited mostly during diastole, but also to some extent during systole as a result of a commissural fusion, caudal thickening, and caudal fusion. While type 3B, mitral regurgitation displays a left leaflet tethering caused by papillary muscle displacement, resulting either from the localized ventricular wall dyskinesia, as seen in the ischemic cardiomyopathy, or a global dilatation of the ventricle, as seen in the end-stage cardiomyopathy. So these are the nomenclature which we have to be clear before going into repair. That is the prolapse, flail, and billowing. In prolapse, the leaflet body is above the plane of the annulus, while in flail, the leaflet tip is in the left atrium, while in billowing, the coaptation zone of AML PML is below the annulus, but the body of the leaflets are above the plane of the annulus. So mitral valve exposure surgically, extracorporeal circulation has been instituted. If pericardial adhesions are present, has to be released up to the apex. Left atrial atria can be approached through the interatrial approach or transeptal approach. Interatrial groove is dissected and the two atria are divided up to the fossa ovalis, incising the roof of the left atrium after the heart is arrested. Incision is extended superiorly to 1 centimeter from the SVC and inferiorly to the midway between the right inferior pulmonary vein and the IVC. So this is the surgical exposure of the mitral valve, which is very easily well exposed in transeptal approach. This valve analysis has to be done, like echocardiographic findings has to be confirmed on table. Functional type of the lesion should be identified, and segmental localization has to be localization of the pathology should be done. So segmental analysis of the mitral valve, first we have to see the atrial inspection, wherein we identify the endocardial thickening, thrombus in the left atrial appendage or LA, calcification of the leaflets of the annulus, jet lesion by indicating the leaflet prolapse. Second is the mitral annulus, which has to be inspected, wherein annular dilatation that is identified, which is symmetrical or asymmetrical. Second, the calcification or the fibrous deposition in the annulus, if it is seen. Third is the leaflet inspection, which has to be done in a specific manner. With the help of a two nerve hook, leaflets are examined, issue liability and leaflet motions are analyzed. Beginning at P1 segment, proceeding clockwise, the free edge of the P1 typically serves as the reference point, since P1 is more rarely affected by abnormal leaflet motion than other leaflet segments. If P1 motion is abnormal, another segment should be identified to serve as a reference point. Whenever a prolapse involves all the leaflet segments, one segment should be corrected first, with the annulus serving as the reference point, and the remaining segment should be corrected using as the reference point. So this is the exposure. The traction sutures are first placed around the main chordae of the anterior leaflet. Posterior traction is given along the posterior mitral leaflet. Exposure of the posterior papillary muscle requires the placement of the atraumatic retractor in the P3 region with the help of a Rezano forceps. So main principle of the valve reconstruction is mainly the one lesion, one principle, which has been explained by the Carpentier. Preserve or restore normal leaflet motion. That is respect or resect principle. Create a large surface of coaptation, remodel and stabilize the annulus. So in first type 1 dysfunction, we'll see the techniques involved. Mainly we will see on the annuloplasty. These are the methods which has been already done. That is the Lillehei, Davile, Belcher, and lastly in 1968, the annuloplasty ring concept was introduced by Carpentier. The remodeling ring restores the normal systolic shape and the size of the annulus, a condition needed for the optimum leaflet coaptation. So as we see, if it is a symmetrical, the anteroposterior diameter will be more than the transverse, while in asymmetrical, we have the different angular measurement more than the AP or transverse diameters, which has been corrected by the annular remodeling ring. So these are the three basic rings which has been used in the market, that is classic, physio ring and ischemic rings. So classic rings used in rheumatic heart disease cases, which is a rigid ring which is open and made of titanium core with a saddle shape, while physio ring most of the time used in the degenerative valve disease, that is a semi-rigid ring, a complete ring with a AP diameter more than the transverse, and the orifice area is more. And it's also of a saddle shape made of alloy and mylar plastic material. While ischemic ring, it's a mainly used in 3B lesions. It's a rigid, complete ring made of titanium structure, has a reduced AP diameter and asymmetrical shape, compensated the tethering of the. Basically, ischemic ring is used in a asymmetrical dilatation of annulus. That is most of the time seen in ischemic cardiomyopathy. So ring selection, uh, before that, for that we have to measure the anterior leaflet and the measurement of the height, and also the posterior leaflet measurements. So in the measurement, anterior leaflet, we have to measure the base and the height. So for that, we should not confuse a commissure with a trigone. So these are the trigonal sutures to make the AML more prominent. To identify the commissures, which is very close to the trigone, we have three methods. That is, identify the commissural chordae and the papillary muscle. And by extending the AML, we can get a furrow, which can be extended to identify the trigone. So once the commissural sutures have been placed, traction is applied on them to slightly distend the base of the anterior leaflet. Then the distance between these two sutures, that is intercommissural distance, is measured using specifically designed sizers. So each sizer presents two notches which should be positioned to match the commissural sutures. Uh, the first diagram, that is A, the ring is too small. On the right hand side, the B diagram, it's a too large ring, and the perfectly fitting ring is fit, that is in the C diagram. In first case, a larger sizer should be selected, while in second case, we can use a smaller sizer to be intertrigonal. Then measuring the height. For measuring the height, we have to unfurl the anterior mitral leaflet, the downward traction on the marginal chordae using either two nerve hooks or right angle can be done. The sizer selected from the measurement of the intercommissural distance is positioned to cover the entire surface area of the stretched anterior leaflet. Three scenarios may arise on doing this. In most of the time, that is 90%, a good correlation is found between the intercommissural distance and the height of the anterior leaflet, as demonstrated by the free edge of the anterior leaflet not extending more than 2 mm beyond the inferior edge of the sizer. In this case, a ring number is selected according to the sizer, and the ring, according to the pathological process, should be decided. In case of discrepancy between two sizes, always choose a larger size, excepting a except there is a spelling mistake, except in 3B dysfunction. There is downsizing is done. If free edge of the anterior leaflet extends 2 to 4 mm beyond the inferior edge of the selected size or one sizer, large physio ring is used to prevent a risk of SAM of the anterior leaflet. In a rare instances, a free edge of the anterior leaflet extends 5 mm or more beyond the inferior edge of the selected sizer. In this case, one size larger classical ring should be selected, the vertical diameter of which is increased by bending its extremities to match the height of the anterior leaflet. Measurement of the posterior leaflet, which is necessary to avoid the SAM. So, to avoid SAM, the greater majority of the cases, the leaflet height is between 10 to 15 mm, and it should not cross 20 mm. So ring implantation. Proper place. So we'll describe it into two parts: proper placement of the sutures within the annulus fibrosus to avoid the ring dehiscence, and second is the accurate placement of the sutures into the prosthetic ring to avoid the annular distortion. So ring implantation is achieved by placing a series of 12 to 15 to 20 matrix sutures through the mitral annulus. The use of 3/8 curvature needle is preferred. Placing the sutures within the annulus. Proper placement of the suture first requires a correct identification of the mitral annulus. The annulus, which is not visible, is located at the atriovalvular junction 2 mm external from the well visible hinge of the mitral valve leaflet. The hinge is exposed by grasping the leaflet transversely and not vertically, and as close as possible to the annulus, exerting a downward traction. This maneuver creates a slight vertical plication of the leaflet tissue, which facilitates the position of the sutures. Yeah. Some slides have been deleted. In the techniques, I will be proceeding with the techniques of AML prolapses. The free edge of the leaflet remains at the same level and 5 to 10 mm below the plane of the orifice during systole to ensure the proper leaflet coaptation in the valve competency. In type 2 leaflet prolapse valve dysfunction, in which free edge of the leaflet overrides the plane of mitral orifice. Anterior leaflet prolapse should be differentiated from the billowing leaflet seen in Barlow's valve, in which the free edge of the leaflet remains below the plane of the mitral annulus. The one lesion, one technique principle facilitates the choice between the different technical options. The limited prolapse, defined as a prolapse involving less than one-fourth of the total length of the free edge of the anterior leaflet, can be treated by a leaflet triangular resection or a leaflet fixation on secondary chordae in both chordal elongation and chordal rupture. The leaflet triangular resection, wherein only 10% of the anterior leaflet surface area is resected. The limits of the prolapse area are identified by the adjacent non-elongated chordae. The two nerve hooks or two stay sutures are placed around them. A gentle traction allows a visualization of the triangle of tissue to be resected. If B measures the base of the triangle and H as a height, then H should be slightly longer than the B. So Phio suture is placed to identify the vertex of the triangle. The triangle resection is carried out with a curved scissor in order to produce a slightly convex curvature on the two sides of the triangle. This provides an optimal curvature to the repaired leaflet. The two edges of the leaflets are then sutured using 4O or 5O polyester suture, depending on the thickness of the leaflets. The sutures can be everted or preferably inverted to provide a more regular surface of coaptation without producing protruding knots. Once the sutures have been completed and tied, two nerve hooks should be used to detect the residual defects. If present, it should be taken care with an additional inverted 5O sutures. The leaflet fixation on the secondary chordae. On secondary chordae is indicated whenever a strong, at least 2 mm thick, non-elongated secondary chordae is less than 5 mm from the free edge of the well-pliable prolapsed segment, for which we should get a secondary chordae close to the prolapsed segment. Two 5O monofilament sutures are placed through the chordae, taking two-thirds of the thickness and then through the leaflet free edge at the corresponding levels. The sutures are then tied and cut. An alternative technique that avoids knot protrusion implies that the same end of the 5O suture is passed first to the chordae and then twice through the leaflet edge and then tied with the other, and so that the knot is positioned under the leaflet. When the distance between the chordae and the free edge of the leaflet is more than 5 mm, a secondary chordae transposition is better than a secondary chordae plication or fixation. Extensive prolapse caused by caudal rupture can be treated by secondary chordae transposition to the leaflet margin, caudal transposition from the posterior leaflet, or caudal replacement using an artificial chordae. Anterior leaflet secondary chordae transposition, it is indicated in under three conditions, that is chordae attachment to the papillary muscle situated underneath the prolapse are selected, thick and resilient secondary chordae are chosen, remodeling annuloplasty ring is implanted to restore the large surface of coaptation. So one or two secondary chordae selected depending upon the extent of the prolapse. These selected chordae 1 or 2 mm from the leaflet margin attached with a gentle traction is applied to avoid the invaginating the leaflet tissue, as perforation may happen. The secondary chordae attached to the belly of the leaflet are usually a few millimeters longer than their marginal counterparts. The length of each detached chordae is compared to an adjacent non-elongated chords. At the free edge level, a mark can be made on the detached chordae using a surgical marker. A 5O monofilament suture is placed through the whole thickness of the chordae at the appropriate level and then through the leaflet edge. The upper end of this suture is then placed twice again in the same manner, thus forming a double figure of 8. The knot is ideally positioned underneath the leaflet free edge. Interrupted 5O sutures are used instead of double figure of 8 figure configuration. The optimum number of chordae that should be transferred to the leaflet edge is based on the following principle, that the distance between the new positioned chordae and the already existing chordae should be 4 mm. So posterior leaflet chordal transposition, the segment of the posterior leaflet facing the prolapsed area of the anterior leaflet is identified. The 3 mm wide strip of posterior leaflet is resected and mobilized to the approximately equal to the length of the prolapsed area. Papillary muscle head attaching the corresponding chordae is mobilized towards the anterior leaflet by splitting. The posterior leaflet strip is reattached to the free edge of the prolapsed area using 5O sutures. The posterior leaflet is then reconstructed by closing the defect. The 5O suture is passed at the two extremities of the resected area. Then gentle traction on these sutures produces a plication of the leaflet tissue, which is secured by an interrupted 5O sutures, thus effectively restoring the leaflet continuity. Coming to artificial chordae introduced by Robert Frater, wherein we use a polytetrafluoroethylene chordae, poly or CV4 sutures, also referred. Sliding characteristic of the PTFE thread make it difficult to tie the knot. This difficult explains why so many techniques have been proposed where whatever the technique chosen, the reference point method serves as the guidelines for the adjustment of the length of the artificial chordae. Adjustment at the leaflet level. The non-elongated reference chordae is pulled upwards by a nerve hook or a 2O traction suture. Its length is measured using a graduated hook. A 5O double-armed PTFE suture is placed through the fibrous cuff of the tip of the papillary muscle corresponding to the prolapsed area, carefully keeping the suture 2 to 3 mm from the adjacent native chordae. This suture is passed once again to achieve a figure of 8 fixation and then tied, leaving two ends of equal length. Flagets are used only if the tip of the papillary muscle is muscular rather than fibrous. One end of the PTF suture is passed through the free edge of the prolapsed area. Using the long non-elongated chordae as a reference, a mark is made on the artificial chordae at the appropriate level. Another alternative is to use the graduated hook. Other end of the PTFE suture is then passed 3 mm from the insertion site of the first end to the free edge of the prolapsed area, taking care not to cross the native chordae to avoid the caudal abrasion. So this is how we take the suture from atrial side and then tie the knot towards the ventricular side and bury the knot below the leaflet. Adjustment at the ventricular level. In this technique, one single plageted PTFE-5 suture is passed first through the tip of the papillary muscle corresponding to the prolapsed area, then through the leaflet edge, and then again through the papillary muscle so that the loop is completed. The knot is positioned on the papillary muscle. Another loop is completed. The sutures are tied, adjusting their length while exerting an appropriate tension on the free edge. An excellent alternative technique has been proposed by Van Appel to minimize the problem associated with the artificial chordae adjustments. So last methods of caudal elongation. So prolapse caused by caudal elongation, corrected by papillary muscle sliding plasty, caudal shortening, and papillary muscle shortening. These techniques are basically used in degenerative valvular diseases. Papillary muscle sliding plasty, wherein we will split the papillary muscle, and then while measuring the prolapse segment, correspondingly we will split and bury the papillary muscle to the adjacent healthy papillary muscle. So caudal shortening, which has a high incidence of failure because of the necrosis. We split the papillary muscle in the core, so it will lose its vascularity and further cause a recurrence of a MRs. Caudal shortening is indicated when there is severe prolapse and elongation of the chordae is more than 10 mm. Papillary muscle shortening. Anatomical conditions required for the papillary muscle shortening and excellent exposure to the subvalvular apparatus and the bulky type 1 or type 2 papillary muscle should be there. The height of the wedge resection does not need to be greater than the half of the degree prolapse because of the compression achieved by the large vertical bites used for reconstructing papillary muscles. So the wedge of the papillary muscle is resected according to the measurement of the prolapse, that is half of the prolapse segment, and then sutures are taken to fix it with a 4 monofilament sutures. So papillary muscle rupture, which is fixed with detachment of that, cleaning that part, resecting the necrosed debris, fixing that this is the debridement of the necrotic tissue, then fixing it to the nearby next adjacent, along with seeing the segment of the mitral leaflet. Fibrous cuff is grasped with the forceps and it's fixed with a subvalvular level. Incision is made in the endocardium in this manner, and if the chordae itself is there, where there is no papillary muscle, we can fix it with a 4 mattress sutures with a fibrous cuff. in this manner. So rupture of the papillary muscle head. Papillary muscle head is sutured to the fibrous tip of the papillary muscle. Artificial cordace can be used. If in papillary muscle elongation, if the papillary muscle is fibrotic and its attachment to the ventricle wall is adequately strong, a resection of the appropriate extra length and reconstitution of the continuity of the remaining segment carried out. So in this according to the elongation measurement, we can plicate the papillary muscle.
Good. I particularly liked your this thing about the transesophageal assessment. You know, that is very important for every surgeon to know pre-op or intra-op how to detect the lesions, and then what are the things to measure and how to what measures, what type of repair is to be done. I have 3 questions to ask you. What is the size of the ring or this thing that is used to avoid SAM, and what is the size of the ring that is used in ischemic MR, and what is the size of the ring that is used in degenerative MR? You know, the sizes, what you measure, and then what you in 3 conditions, the sizes, either you have to use a smaller ring or a larger ring that is advocated. So what do you think it is?
Sir, more than the ring size, the PML length, which is more taken care, sir, while repairing, it should not cross more than a 15 mm, sir.
No,
Most
that
of
is
the
okay.
time in RHD cases,
The cooptation area is different, but then when you choose the ring size, there are specific guidelines that they have advocated, that you know the ring should be either a little smaller in particular condition and little larger in another condition. I am not too sure exactly which is which, so I wanted you to let us know, or if you don't know, please check with your consultants who are practicing this repair and let us know.
yes, sir. Yes, sir.
Sir, you have any information on that, sir?
No, I thought ischemic MR very often you undersize ring, you know. And there are 3 basic principles for selecting the size of the ring. One, you measure the intercommissural distance because it's continuous with the subaortic curtain and to the aortic annulus. That area cannot be shortened, so that is fixed. And you didn't mention that, you know, the attachment of the anterior leaflet is to 1/3 of the annulus and 2/3 of the annulus is the posterior leaflet. And I should first measure the intercommissural distance. Number 2, the length of the anterior leaflet. Number 3, the area of the anterior leaflet. So these 3 measurements are used to get the correct size of the ring. The indications are for, because very often when you undersize the ring, it's chance of a SAM, I think. So that's all I know. The only thing is that you mentioned a lot of things, and the most important thing is that the mitral annulus, you mentioned that it's a dynamic structure, not a fixed structure. It's in diastole, it's a circular thing, but in systole, it's almost like a table shaped. Other thing you mentioned that about the, Carpentier classified the A1, A2, A3, P1, P2, P3, and in most of the prolapses, he saw that the P1 gets least affected. So P1 is taken as the reference point, and then you take either stage 2 and fill up the ventricle and see which part prolapses so that you get an idea. And you didn't mention more details. You meant a lot of details about the papillomavirus, about the primary, secondary, and tertiary college. That thing you didn't mention. Classically, in perhaps the older time, I'm saying in the 80s, the main method of repair was a triangular resection for anterior leaflet collapse and a quadrangular resection in a posterior leaflet. And quadrangular resection is always associated with a sliding annuloplasty. Because when you do a quadrangular resection, you cannot join the and suture end to end, these two resected portions. So you have to do a sliding plasty. That means separate the annulus of both of the resected on either side of the resected. A sliding plasty, remove that, then suture the annulus, the valve leaflet back to the annulus, and also suture the defect you are produced by quadrangular resection. This used to be the classical method. Then you use a ring actually. Then I think this is your first part of presentation. Next part, get a surgeon who will describe to you what exactly done and also how to select a ring. Whether it's a rigid ring, whether it's a semi-rigid,
Sir, we are not able to hear you very well.
Whether to select
better now.
A completely rigid ring, semi-rigid, or completely flexible ring. All those things come next time and present. That will be better. And there are some newer techniques and also the catheter-based techniques, which I don't know how good it is. Catheter-based transeptal annuloplasty, then about the microclip, the stitch, all those things, comes in the repair. So actually get a surgeon, and then in an exam you must say what exactly is being done. And I read yesterday there's a new technique by the Japanese, outside technique for posterior valve prolapse or posterior leaflet prolapse. There's a butterfly resection of the posterior leaflet without using an annuloplasty. It's known as the butterfly technique, in which he says the chance of SAM is least. So when you complete this talk, get an expert, because you have so many things, and most of the things you described earlier, like a caudal transfer, the shortening of the caudal, all these things have been replaced by vortex neocordial technique. You must know in an exam what exactly is the practice. So get a surgeon and describe what exactly is done in our.
See, basically in repair, you must know what are the measures that you use to avoid SAM. What are the measures that what are the things that you use in an ischemic MR, and then what are the things that you use in a degenerative MR, and when do you use a complete ring, when do you use a incomplete ring, the rigid ring and flexible rings. These are the things that you have to know when you are doing a mitral valve repair. Okay?
Yes, sir.
And also find out what ring they are using. Is it a Carpentier PCO2 or the Foxtrot Edwards ring or the St. Jude ring or the Abbott ring? There's so many of them available now. So you must know what exactly we are using.
So most of the time we will use a 3D profile physio ring, sir.
Okay.
3D profile.
Yeah, just like the valves, you must know the different models of the rings available and the pros and cons of each of them, and
Yes, sir.
what we use regularly in our hospital. These are the three things that you should know when you are talking about ring annuloplasty.
And that time you also mentioned the types of ring, the complete ring, which in the mitral is like a D shape. The incomplete ring is in C shape. And generally the rule is that you use mainly a semi-rigid complete ring. You use 50. So you find out what exactly we are doing in our hospital. But that's what you have to answer in an exam.
Yes, sir.
Karan, I want to tell you to make a list of the topics that are going to be done for the next 2 months.